let's get 2 minutes on the clock and your time starts now. Case 3. Billy, a 3-year-old boy, presents to your GP clinic with a cough and loud breathing that started overnight. His parents report that he had a mild fever yesterday, but is otherwise well. They note that his symptoms worsen at night and improve during the day. On examination, Billy appears alert. His temperature is 38.1 degrees Celsius, his heart rate is 100 beats per minute, normal being between 80 and 120, his respiratory rate is 24 breaths per minute, normal being 20 to 28. His oxygen saturation is 98% on room air. Question 3.1. What examination findings would be consistent with a diagnosis of croup for Billy? Provide 5 specific examination findings. Alright, time is up. Let's get to the answers. So, for Billy here, we'd be looking for things like that classic barking cough. Certainly going to be almost pathognomonic for croup, and so 2 marks will be getting there. Of course, you also often hear that inspiratory stridor to auscultation of the chest, 2 marks. You would expect to see increased work of breathing or accessory muscle use, again getting you 2 marks there, and sometimes you see, particularly in more severe cases, hoarseness or changing of the voice. Sometimes, in addition to the inspiratory stridor, you'll hear a widespread wheeze. There's a tongue twister for you. Say that 10 times fast at 9:15 at night. And, of course, you can also get fever. In the setting of croup, though, it's fever without signs of toxicity is one of our diagnostic markers there. Now, this is directly ripped from the Royal Children's Hospital Melbourne croup page, and if it's not something you're familiar with, definitely have a read through. A lot of little gold nuggets in there. Of course, we've got some things in from the chat. So we've got expiratory wheeze, fantastic. Intercostal recessions, beautiful, tying into that worker breathing. Altered conscious state, not in here, but definitely I think would be... I wonder if that would be more of a sign of infection rather than a specific diagnostic feature of croup. Inspiratory creps, probably not so much. The creps would tend to imply more of a lower respiratory tract infection, whereas croup is that focal kind of upper respiratory tract there. So again, I don't know if you would get marks for that. And tracheal tug, so again, I think you've got that increased work of breathing, kind of accessory muscle use there. I don't know if you would get intercostal recessions and the tracheal tug kind of playing into it. There's probably a little bit too close a response to those. But again, if you're kind of struggling to think of other things, certainly quite good to try it out. Jenny here, we've got barking cough, fantastic. Presence of stridor, brilliant. And hoarse voice, very good. Got to 3. 3 out of 5 ain't bad. If you get to that point as well and can't think of other things, kind of take that step back and think, well, what else do I see with upper respiratory tract infections? And sometimes you can sneak another 1 or 2 out from there. Again, it can be a little bit tricky to kind of find things, but sometimes a good peck around and scratch around, you might dig 1 or 2 extra marks up. I would say from the responses you got there, though, you'd be passing that question. All right, of course we've got more questions here. Let's get 2 minutes on the clock and your time starts now. Question 3.2. You diagnose moderate severity croup warranting treatment. What initial management is appropriate? Provide 3 management steps. Doses are not required. All right, time is up. Let's get to some answers here. So, things here we need to do for moderate severity croup. This is again using Royal Children's Hospital guidelines. These tend to marry up quite well though with the ETG recommendations as well, except we'll put a little asterisk in there. We'll come back to that shortly. So, commence oral prednisolone or commence oral dexamethasone. It'll be one or the other. Either one will get you 2 marks. Doses aren't required here, but for your interest, because I know you're interesting. Oral prednisolone, we're using 1 milligram per kilogram up to 50 milligrams as a single dose. Now that's if you're using one of the guidelines. If you're using the other, they will specify plus, with or without a repeat dose the following evening. I would use your clinician gestalt and opinion, what you're more familiar with doing, what you're more comfortable with doing to dictate which one you use. I think there is a lot of ambiguity as to how much benefit you get from the repeat dosing, and so that's a call you would have to make. Now, dexamethasone, 0.15 milligram per kilogram up to 12 milligrams as a single dose. And often for those kids that come through ED, they tend to get the dexamethasone I think simply because it's a one and done kind of thing. There's no ambiguity around subsequent dosing. Guidelines used to say 3 days of oral prednisolone, but it can be quite difficult, and anyone that's seen kids on steroids knows they're not always the most pleasant little creatures to be around. Now, another piece of management here is to assess if no improvement after 30 minutes following medication, if improves, after 30 minutes following medication, they can return home. As a separate line, advise if they fail to improve 30 minutes following medication, or, and this would probably be a separate mark and would fall into that grouping category, so I wouldn't be putting both of these, or if they develop stridor at rest, they should immediately attend the emergency department. 2 marks there for that safety net aspect of you're not just saying, here's your tablets, good luck, go out. You really do need to make sure for croup cases, because they crash very, very quickly when they do become sick, that you've got that safety net in place. They know what to do if things don't go according to plan. Now, a bit of kind of more generic upper respiratory tract infection advice here is to encourage, but do not force, small sips of fluids regularly to try and keep up the hydration. These are kids that it's often quite uncomfortable for them to swallow, and so they can dehydrate quite quickly. 3-year-old as well, they don't tend to have as much reserve, and it's a tricky thing because hypertension is a really late sign of decompensation in kids, so you really want to try and make sure you've got a buffer there, because it's one of those ones that can be missed. Now, good to specify here, do not force, because if you cause distress to a child with croup, you are going to make their airway compromised and make it more difficult to manage. And so it's more that gentle reminder, have those drink bottles handy, just a clinical tip. And of course, symptom management, commence paracetamol or ibuprofen if Billy has pain / is grizzly. Now, massive overcoding on that response there. So I would put commence paracetamol for Billy if he has pain, or ibuprofen if he is grizzly. You can tie that back and forth as long as you're putting some kind of sensible response in that ballpark there, you're going to get a mark. Now coming in from the chat here, we've got transfer to ED. And yes, moderate severity croup, I think if this was something that you didn't feel comfortable managing yourself, it's actually not unwarranted, I think, to transfer to ED. And I think you probably would be getting probably 1 mark for that if you did have particular concerns. I think in this case in particular, the thing that they're trying to steer here is that this child does have normal vital signs, normal respiratory rate, and good oxygen saturations. And so I think it would be, for a consultant level exam, I think what they're trying to tease out here is this something that you think you are able to manage? And I think they're pushing more for that. I'll be honest though, yeah, I think you still would get 1 mark for transfer to ED. Dexamethasone, fantastic. And positional, setting them up. I think that's certainly an important thing to do. Positioning is a really key thing for management, probably heading more towards that moderate to severe croup in terms of putting them into a position that they can maintain themselves and trying to touch them as little as possible. So, well done. All right, we do have another question here. Let's get 2 minutes on the clock and your time starts now. Question 3.3. Billy's parents return that evening, panicked. Billy is crying, seeming drowsy and pale. They tell you his condition had worsened slowly over the day until he became upset after the TV was turned off. His condition rapidly deteriorated, and in a panic, they drove to your clinic only a minute away. You bring them to the clinic procedure room. What is your initial management actions? Provide 5 management actions. Doses are not required. All right, time is up, and let's have a look at some answers here. So, in this situation, the patient has obviously progressed through to serious croup, and I anticipate you're probably experiencing some anal flutter. This is one of those times where you call for friends, and my friends in this situation are 000 for an emergency transfer to the emergency department. So I think for 3 marks there, you need to specify that it's 000, it's an emergency transfer and destination to emergency department. Seems pedantic, I know, but this is one of those things that comes up again and again, 3 marks for those 3 components. Now, in this severe case, we're going straight to our nebulized adrenaline. So you can just use the 1 in 1,000 adrenaline ampules, just cracking open one of the 5 ml ampules straight into there. Now, of course, to get 5 ml of it, you're cracking open 5 ampules. And having gone through this myself, it takes a while, it takes a bit of practice. And you're sitting there trying to draw up all this adrenaline while the kid's sitting there desperately trying to breathe in front of you. You've just got to take a deep breath, step through, and get through. Now, anyone that's tried to give nebulized adrenaline to an unwell child knows it's not a pleasant experience for them, and they will not let you put a mask on them. So sometimes just having the mask nearby so that the nebulized mist is spraying to their face is one way to start getting it in, and as they start to perk up a little bit, you can hopefully get a mask on them then. But it's essentially try and disturb them as little as possible, because with croup, with that upper airway obstruction, really easy for them to again become upset and decompensate. Now, we gave some dexamethasone earlier, but we're going to be giving more dexamethasone. The goalposts have changed here, and we need to up that dose to 0.6 milligram per kilogram, up to 12 milligrams. That can be given orally, as we may have done earlier, or you can give it intramuscular or IV, depending on how quickly, how aggressively you want to manage. Acknowledging as well, though, that those other routes may actually cause more distress than it's worth. Here you definitely get marks for minimising handling to avoid worsening symptoms, given the profound impact that it'll have on trying to aggravate the child, causing worsening symptoms. Of course, keep the children with carers to try and reduce stress. Have as many familiar things around them as possible to help calm them down. A calm croup is a croup that lives. And as has already been specified earlier, allow the child to select their position of comfort, however they want to sit. And in a couple of cases, I've said, well, one of the cases at least, the kid just wanted to sit upside down on the bed. Sure, that's fine. That's how he was comfortable, and that's what we let him do. Now, one point that has come up time and time again is for these cases, obtaining intravenous access is actually recommended to be deferred, given the distress that it actually places on these children. Of course, if the patient becomes unresponsive, unconscious, those goalposts change, and I think it would definitely be warranted. But while they're in that kind of conscious state, you're really trying to disturb them as little as possible. And so, again, I don't think we would get marks in this setting. And to be honest, in this setting, if a child did become unconscious, I'd be very tempted to just pull out intraosseous, given these are kids that are probably quite dehydrated already. And when you're struggling to get access on a child, you can waste a lot of time laughing about trying to get intravenous access, particularly if it's not a skill that you practice often. I think often much safer, much easier, so much faster. Just pull out an easy IO and put an intraosseous line in. I'm presuming you have one handy and, of course, are comfortable doing it. If you're not, please do some YouTube videos, do some training. It's a very, very handy skill to have, particularly if you're working in a regional remote setting. All right, so let's have a look at what our responses are here from the chat. So we've got Ambos 000, fantastic, very well done. Oxygen, this is another one of those things where there's a little bit of ambiguity for this patient here, to be honest. Yeah, I actually would give you marks for oxygen. You know, they're drowsy and pale, they're hypoxic. Whether or not you actually strap a mask on them, or similar to the nebulizer, just have it nearby, getting a bit more kind of passive, increasing their FiO2. Nebulized adrenaline, brilliant. IV line, I've already spoken about that. I probably wouldn't give you a mark for that one in this setting unless they did become unconscious or further deteriorated. And more dexamethasone, fantastic. Very well done there. From Jenna here, we've got regular monitoring of vital signs. Yeah, not in here, but actually very, very important. I don't know if you get a mark for this question here, for the specific thing here if they've said, what is your initial management actions? Whereas that would probably veer into that territory of ongoing management. Sorry to be pedantic. Call ambulance to organise ED transfer. Excellent. That would get you 2 marks there. I think I know it's stupid. I know it's pedantic, but specifying urgent gets you the 3rd. Keep Billy calm and quiet with his parents. Fantastic. Really love that. Start oxygen, as I said, yep, I would be giving you marks for that. And give stat dose of prednisolone. Fantastic. Very well done.